because they went to some areas with less, that they had not been screening for some time, so it was a certain peak of cases there. We have had another peak in 2022. That is due to some increase in the cases in Central African Republic and in South Sudan. We know that now small changes in some countries, they can change a lot the curve. But, well, that's the situation. We go in this small reduction. If we keep in this trend, it will take a long to reach the 0 cases. Probably will not be reaching in 2020, in 2030. So what we think, it has been talked also this morning, we have to see, well, what do we do with the strategy? The current strategy of HIT has been based in 4 elements, in 4 pillars. One has been the passive screening that has been done in these health facilities in remote areas. It has been reinforced with the arrival of rapid tests some years ago. We have been doing also, that it has been an important part of the game, the active screening. And, well, it was based in these mobile teams with different approach, with small mobile teams, and based in the use of the CAT. With those elements, we have been doing active screening. And then it was important, all the cases that were detected were treated, and we ensure the treatment of these cases. And the 4th pillar of the 4th pillar of the issue was the vector control, as it was said before. So all this strategy needs to be adapted. How to adapt this strategy? We know we have to keep on doing the same things, but in a new situation. So the passive case detection has to be more and more integrated in the primary health care. It has to be combined with the reactive screening in the areas where we are detecting cases. The active case detection has to be very well targeted. It has to be adapted to new situations. We were listening our colleagues from Guinea talking about these door-to-door mini mobile teams. We listen from the DRC colleagues. And, well, to adapt to this situation and to try to keep the community involvement in this situation. We need more and more referral institutions that they are able to perform confirmation tests that they will be more and more difficult to perform in the field. For the case management, we'll need to adapt this situation and to look for simpler tests, more easier to be used by staff that is not specifically trained. And, well, if we reach to get these simpler tests, we can go for a strategy that we don't need in the field this confirmation of the cases. If we have a safe treatment, we could do an easy test and an easy treatment combined together. It has been talked this morning. And about vector control, well, we have to adapt to more affordable tools. We need to involve community, and we have to target very well the areas where we are doing vector control. So, what are the challenges? The main challenges to integrate passive case detection is that we are working with very weak primary health care system. We work in remote areas where this system is very, very weak. For active case detection, we have talked that, well, more and more the participation and involvement in the community is worse. The community is not participating so much in this active screening. And also for the case detection, that, well, the tests we have, they are still limited. We don't have the current tests available. They are not ensured the availability for the coming years. We have, it has been talked also this morning, the people who knew very well to do the diagnostic, they are becoming older and they are going to retirement, and it's difficult to train new people when there are no cases. We need more simple referral tests. The tests we have now, they are still too cumbersome. We have logistical problems to ensure the transfer of samples. And well, all these are challenges for the active screening. For the case management, the drugs we are still using, they are complicated to use. In some cases they are toxic, but we have better drugs, but still they are not simpler enough to be used by staff that has not complicated training. And also it's not the current drugs, they are not covering all the population, they are not covering, for instance, the children. For the vector control, there is fewer staff training to do vector control, and the community involvement in vector control is still limited. Well, with all these challenges, where are we? There are also some other more general challenges. We are always exposed to unexpected events like insecurity situations, social disturbances, natural disaster, or epidemics, as we have seen recently with the COVID pandemics. Also, well, we have still limited knowledge about the role that human and animal reservoirs are playing in the transmission. Another challenge is, well, we know that we are working, and it has been very well described this morning, in transboundary foci that they have been coordinated with both sides of the disease. And also, well, there is still a weak ownership by the countries of the elimination. They are just waiting. This a thing that is coming from outside or from the programs, but at the central level of the Ministries of Health, sometimes it's not well understood, this issue of elimination. And also, well, we have now important donors, important partners, but it's not ensure a long-term the maintenance of this partnership. So what are the opportunities? At the same time, we have things that they have moved ahead. We have these tests that they are, and we will see in the coming presentations, they are we are trying to improve the test available. We hope that they will be working better. There is a good research going there. We are widely using these rapid tests, but still a room for improvement. Also for active case detection, there is a kind of social research to see how we can approach better the communities. And the last day there will be some presentations about that. Also, well, we are working, and we'll see a lot in these days, about the referral tests, how to improve them, how to improve the transfer of samples from remote areas to these reference labs, how to support these referral labs. So in the diagnostics, there are a lot of improvements coming. Also in the treatment, we have still ensure, and we have ensure up to 2030 the availability of the current drugs, and they will be available. And there is also important research in new drugs like dacosiborol. We have already a new study that is showing that looks like an effective and safe drug, easy to use, and it can change also the game in introducing this test and treat that we can support the integration in the health system. And for vector control, yeah, there are some research we will see also during these days about how to involve community, how to adapt these tools to the new situation. Tiny targets that there is affordable methods more and more used, but we have also another methods to be used. At the same time, well, we have some results to show about the elimination that can help us to raise awareness and to see that reaching 0 cases is feasible. We have been able to reach less than 1,000 cases coming from where we were coming. And now, well, we can show these results and to say, well, if we keep on working, we will do these activities. We have seen the resilience of the national control programs in a situation like COVID to be adapted to this new situation, to face these problems. There are studies on human carriers and animal reservoirs to understand better the epidemiology. There are some countries that are showing a lot of interest to reach this elimination, and there are countries they want to campaign to be there in the elimination of the disease. We expect that the donors, if we are showing these results, they will keep on supporting us. And important, and it has been shown before, it's important to keep this coordination between different stakeholders and try to push all in the same sense. So I think we are a bit... 2 minutes. 2 minutes. So we are moving ahead with the countries to go for elimination, but the activities we have to perform in the different countries, it cannot be the same for all the countries. We have countries in different situations, and according to the situation of the countries, we have to adapt the situation. It's not the same. Countries that they have reached elimination, that they, as public health problem, that they are not getting cases for a good number of years now, that other countries that they have still areas where the sleeping sickness is a public health problem. So, I don't enter in detail, but according to the situation of the different countries, we can plan different activities, different goals. There are countries, as I was saying, in a situation more advantageous, without cases, that we think that there is no transmission, or countries in a worse situation. It's a fight, with this. Countries in a worse situation like DRC or Congo or Angola, where the situation is still more complicated, and we need still to reinforce control, to reinforce surveillance, to reinforce the activities before going to elimination. But the final goal is to reach elimination of transmission. So just a few words about rhodesiense. We don't have to forget. We can see here in the curve how is the contribution of rhodesiense. In the red line is the cases of rhodesiense. You can see it's much less, but we have not to forget that it's a disease that, well, it's a zoonotic disease, that it means the control has to be has to target the animals, and it has to be integrated in One Health. And also we don't have to forget that it's a disease that can cause some epidemic outbreaks. As it has happened in the last years, we have been some outbreak in 2014 in Uganda, in 2020 in Malawi, in 2022 in Ethiopia. So we have to keep an eye in rhodesiense. And the situation is worse because the treatment is still very toxic. There is no serological methods to diagnose the disease. And, well, we have to work. I have to say that, fortunately, there are some research. We will see some results to be present to develop serological tests for rhodesiense, and also taking advantage the research that is going in the treatment of gambiense to apply these new tools also for rhodesiense. So as conclusions, and I'm finishing, I have to say that the number of cases maintained is now 5 years that we are below 1,000. We can congratulate. It's a good achievement, but we have to go further. So there are some 7 countries that they have been already validated. There are other countries in the pipeline, and we hope one by one, according to the situation, the different countries are joining to this situation of elimination as public health program. As I was saying before, it doesn't mean that the work is finished. Still, elimination as public health problems means that we have to keep on doing things. It is not the final point. And we have to insist a lot to pass this message. So we have seen the impact of COVID-19, and we are exposed to these unexpected events, but we think we can adapt and to work in these situations. The strategies for elimination, as we have been seeing, we have to adapt to this new situation, and important, we need improved tools if we want to reach elimination, and we will see in the coming presentation a lot of efforts to improve these tools. To keep always an eye on Rhodesiense HIT, and also important, we need to keep the donors' commitment, and we have to present results, and we have to work together and to involve them in the process of elimination. We have to insist that the countries, they have to honor the elimination process, and they have to be in the drive. Very important to keep the coordination with the different partners, and here it's ISCTRC's research and control to keep and to encourage the researchers to keep in this operational research to provide these tools. So thank you very much for your attention. Sorry.
Thank you very much, Dr. José Ramon, for this wonderful keynote presentation that is giving us an overview on opportunities and strategy on the road of at elimination by 2030. Je pense que le temps qui a été imparti pour cette présentation, et vu le temps, cette présentation ne donne pas lieu à des questions ou à des remarques. Et je remets la parole au chairman pour le reste du programme.
So another round of applause for Dr. José Ramon. The sessions in the afternoon is related to the presentation by José Ramon. So some of the issues that you may have wanted to raise can be raised after the opening ceremony. Now we are going to close here and go for lunch. And I want to repeat again, because I noticed somebody was trying to open the door on my left. Please avoid the door on my left. Go through the door on my right. We have to come back here and be seated by 1 o'clock. 1 o'clock, we must be back here and be seated for the opening ceremony. Number 3, there is going to be some reorganization. So make sure you know where your personal assets are. If you can go with them, it's fine. But most importantly, the people on the first 2 rows, those ones should be left vacant. So you need to take whatever you have, because there is going to be some reorganization. And when you come back, be prepared to sit somewhere else, because some of the seats in the front 2 rows will be reserved for our visitors. With that, I want to wish you a very nice lunch. Continue with the discussions. Remember, first 2 rows, please make sure they are vacant. The other rows, make sure you know where your possessions are, because there is going to be some reorganization. See you at exactly 1 o'clock seated. Bye-bye. I think they carry their belongings. I don't know what we are doing.